Judith, and probably the reason I'm here is because of the 13 years I spent with the Suicide Survivors of Loss bereavement group at the Crisis Center, and after a couple of years of that, I could not get involved in prevention advocacy. And so I was fortunate to become involved with what used to be the Alabama Suicide Prevention Task Force, started in 2001, and I know a lot of our early leaders are here and members of that organization. We eventually went on to become a 501c3, which is ASPARC, and we like to provide as many resources as we can to all of you and anybody who will consume those resources in the interest of preventing suicidal deaths in Alabama. I definitely wanted to give a big shout out to Renee and Alana and all of their team people for doing such a tremendous job with this conference. I mean, I remember in 2008, we had 4 survivors of loss who came and talked for about an hour, and we had 8 people in attendance. And so it was kind of a 2-to-1 ratio there, and we met in a little room at the Crisis Center. And today I was just sitting here looking at this wonderful sign on the podium, and I'm like, wow, you know, the technology team and the wonderful meal and all of you here, this is just wonderful. And we as a little video organization can't really do that easily. We kind of, you know, meet at the McDonald's over coffee and try to get things done. So just thank you all. And I know that everyone in Alabama might benefit from this indirectly. So I'm just so grateful. The 3 things that I want to do with my time is to talk with you a little bit about the statement of the problem of suicide, to spend a little bit of time on how would you very quickly know how to do a risk assessment with somebody who might be in one of those calls for you in law enforcement, maybe what we call, you know, crisis negotiations. And the last thing is to just pile on as many resources as I can for you. I usually have lots more stuff than I have time to cover, so that will be the case today. But we had worked out an arrangement to post all of the handouts of the presenters on the ASPARC website. And so if you didn't already get a bag, our website is on here, www.asparc.org. And not right now and probably not tonight, and it might be tomorrow night before I can get to it. But all of the PowerPoints that you saw today will be posted on that page. And I'm going to show you just how to get to that. It's .org, not .com. And there are tons and tons of other resources there. So you're welcome to use and get one of the bags that I know many of you have already gotten. But if you didn't know this, inside the bag should be 2 or 3 of these little cards to the Crisis Center. Now, we have 3 crisis centers in the state. One of them, which happens to be the one I'm most attached to, it's in Birmingham, but serving the central region. There's also the Crisis Services of North Alabama and the Mobile Lifelines Counseling and Crisis Center. They're good partners with all of us and everyone here, I'm sure. The Crisis Center in Birmingham is 24 hours a day, every day of the year. And so even if you don't have a need for this card, you might have somebody you need to give this to. And that's what we wanted to do, is to get these distributed to people who might need to call, you know, any time of the day or night. And also on the bag, there's the 1-800-TALK line, which is the National Suicide Prevention Lifeline. Even if you are a third-party concerned person, you can call also, and they will respond to you and help you there. That might be good for a family member or you yourself if you're looking for a consultation. So let's see if I can get coordinated here with the, let's see. So I'm trying to do this in the back, right? There we go. Now, our public health and injury prevention and the Department of Health Statistics in Alabama does a fantastic job, and I just pieced together my data from various resources, most of which come from the CDC. But what you can see here is that in 2014, in the nation, we lost almost 43,000 people in the United States to suicides that we know of. Okay, there are probably a lot more that go unreported. And in Alabama, in the same year, we lost 720, well, over 700. I'm thinking 721, 715, depending on which source you look at. The next slide breaks it down into ages for both males and females. And those are particularly for young people. And then also the youth in Alabama. So if you're on this side of the room, in 2014, we lost 74 young people younger than the age of 25 to suicide. So I'm pointing at the TV, but I should point back there. I'm just providing you with 2 or 3 different slides just to kind of portray what I know every day we all kind of see out there in the field on a case-by-case basis. But the 3 things that I would want for you to be able to take away from the data is that there are 3 ways to think about suicidal, the impact of suicide as a social problem. One would be the incidence of suicide, one would be the cause of death ranking, and one would be the rate of suicide. And if you're a mom or a dad of a teenager, you're probably going to be really interested in the cause of death ranking, because the cause of death ranking is going to be 2nd or 3rd cause of death among all youth. And if you're a public health officer, you might be looking at raw data, like the number of people who are dying from suicide. So incidents, for example, in Jefferson County, we have a lot of suicides, but Jefferson County is a very populous county compared to maybe a Pike County or Clark County or Lowndes County, where the rate is higher than the number of actual people who are dying from suicide. So it's just something to think about, because a lot of people we know that the rate of military suicide is very high, 22 deaths a day, and their rate is actually way up there at about 22%, or a rate of 22 per 100,000. So these are just some ways to look at the impact. And one of them that I think is so alarming is something we don't hear about very often, but the CDC was able to do an interesting study based on emergency room consultations and admits in the emergency room. And if you look at the last point there on that slide, 1 million people a day in the a year, 1 million people a year are attempting suicide in the United States. So not all of them are dying, fortunately, but they may end up with permanent disabling conditions or ongoing difficulties related to their attempt. They are at higher risk for another attempt. And so to me, that's the biggest risk group of all, is everyone who is attempting. And it's not an unimportant thing that many of them, like in the first and second bullets, have thoughts of suicide or an actual plan. So the more specifically a person is thinking about suicide, the higher the risk. And we'll look at that in a couple of minutes. Now, this is such a big setup here. This slide actually is very interactive. If you wanted to go to the website that's listed up there on the top, you could enter, click on the age group or the county in Alabama or another state and actually see how many deaths to suicide are happening in a very specific way. So if I could get live online connection right here from this podium, I'd be able to show you those different things. But that's an interesting resource if you're looking for your particular county or a particular age group that you're serving. This is the cause of death ranking, and in the United States for several years now it's been the 10th cause of death. And I remember back in 2001 in the United States it was the 11th cause of death. And there's just something about things start to happen when it's in that top 10. And we do know that there are so many things that we all can do that help to make suicide preventable. So the cause of death I see on the next slide, that's also from the CDC. This is, so there we go. This is Alabama, and my public health friends might say, well, no, that's not what we have, or maybe it's close, but the CDC is saying it's the 11th cause of death in Alabama. But see, you can look at cause of death ranking, incidence of ranking, and then the rate of death, and they all tell a little bit different story. So for example, let's look at, there we go. This is just for young people younger than age 24, but you can see from the kind of shaded gray areas that those are the second and third cause of death for young people in those particular categories. Younger people tend to not die of other kinds of diseases and illnesses that older people might die of. But even then, if we looked at the rate of suicide for people who are 65 and older, their rate is one that almost rivals the same rate as the military. They have a very high rate of suicide, and with each passing year that number gets more and more, not just only the incidence but the rate when you compare only people in that age bracket. So we have a lot of concern about, as we should, with the military, with children, with Native Americans who have a high rate of suicide, with other risk groups, the LGBTQIA community. And every death we would want to believe is preventable. Zero suicide every day. But depending on your demographic and who you work with, there's a different story there about who is the most impacted. So I guess it's an equal opportunity type of risk. And this is another more detailed chart about ages, age categories, and each year, and what the rate of suicide was. So it's like making the common denominator being 100,000 people in all like groups, and then how do we compare that? So I'm going to just skip on through these and point you to what I think is maybe the most important slide. And this, to me, is where it's at if you're there at the scene, or if you have your client in your office, or maybe you're doing a crisis negotiation, or you're under a bridge helping a homeless person, or it's a military buddy of yours. It kind of doesn't matter which groups are at high risk and which rural or urban or young or old, because in that moment, that person is a one-person sample. And if it's your friend or your loved one or your citizen in your community, that is the most important person at risk in that moment. So I think it's easy to sort of think, oh, well, this is a middle-aged person, and, you know, they're doing well. You know, they are in the prime years of their life, but really anybody can become suicidal at any time for any reason with any method. And over the years, some of my clients that I thought would be the least likely to become suicidal or have an attempt, I learned so much, and it was humbling to learn that, you know, some of the most overachieving people who looked like they were just having a good life would end up in the emergency room sometime over the weekend, and I get a call, you know, on Monday morning or something like that. So anybody can attempt or die from suicide for any reason at any time with any method. Okay. And I wanted to acknowledge that no matter whether we have 8 people at a conference or 175 or so, I know that a lot of you have been exposed to suicide through your work and the trauma that all of the speakers have been referring to. And I know that maybe some of you have been touched directly by the loss of a family member, or maybe even at some point in time you yourself have had thoughts of suicide. And so I just know that that is here in the room with us. So I hope that you know that we're all wanting to champion all of the people who are vulnerable in those ways. And that's partly why I like to do this work. I do find it traumatic sometimes, the exposure to all the suicide stories, but I want to address that maybe as my final remark. What's in it for us by doing this work? And I think we probably have a million other stories on that side of the column too. So the next couple of slides, because I was asked to speak about suicide and guns, this is that part of the presentation. And in a state like Alabama, we probably are a long way away, and maybe the will of the people is to never alter views on the right to bear arms. But just saying, here's a little bit of information about, I think one of the other gentlemen earlier in the last panel spoke to how many people die from suicide with firearms. So this is from 2013 data that I believe comes from the CDC, and you can see that over 21,000, or the majority of those deaths, were from the use of guns, over 51%, and then suffocation, and that would include hanging, about 24%, and then poisoning or drug overdoses or taking lots of Tylenol or whatever it may be. That'd be about 16%. If you add up all the numbers, the chart is going to not come out perfectly to 100 because there's another category in there called undetermined or unable to be determined, and there's just kind of that little error, that little margin of not being sure. But this is another way to present the exact same information, and in red you can see in the first column the number of deaths from cutting, or, you know, some people might die from cutting or piercing their wrists. That's actually a quote-unquote low risk way, but I say that cautiously because people can drink a lot, cut themselves, pass out, and bleed to death. A lot of people who are quote-unquote cutters or non-suicidal self-injurious prone, they would likely not have the intent to die. So that's another workshop on what is the difference between a non-suicidal self-injurer and a suicidal self-injurer, and that's another workshop. But in the second column you have suicide, and then homicide, then undetermined. So by far, in almost all of those categories, the gun deaths are the highest, with over 21,000. So guns are easy to purchase. They're easy to find, even if parents lock them up. Kids have a way of knowing how to unlock things. I know a family where there was some old antique gun that was kind of in pieces in an old box up in the attic, and somehow he was able to put that gun together and go out and use it on himself. One of the most traumatic cases that I recall in the Birmingham region, and it involved an out-of-state family, but it was a mother who shot her child and then herself, and she had gone to a sports store that afternoon and bought the gun and explained, you know, the cashier was kind of worried about it and said, well, why are you getting this gun? Well, just for self-protection. I need this because of my young child. And part of my trauma with that is that even whatever it is now, 12 years later, I cannot shop in that particular sporting goods store. They probably had no idea. It's not personal. It wasn't their fault, so to speak, but that's kind of one of those indicators that I just kind of wince. When my husband needs to go get camping gear for our son, I just say, well, don't go to that store. Go to another store, which may even sell guns. But that's a little leftover sign to me of the kind of the post-traumatic residual. So we may not be able to, and we may not want to do whatever it means to do gun control. So this is not a time today to talk politically about that, but that's always going to be something that people talk about. But a few of the programs, and I want to acknowledge my colleague David Coombs, who was up early this morning on the podium, but Harvard has a good means restriction public health program called Means Matter, which you can check out for greater detail about their approach. And there's another one in Washington State called Lock It Up. And you could Google, there's a brochure, and I forget exactly who sponsors it, but it's a Suicide Proof Your Home brochure, and this would be good for parents to use with respect to things like medication. We cannot get rid of all of the things that people can kill themselves with a sock, and they have before in jails and that kind of thing. Garden hose, you cannot remove everything as a means that somebody might use to die, but we can think about that more intentionally, and so that Suicide Proof Your Home is a way that maybe parents can get behind the 8 ball a little bit more. I remember working with a woman who had a very, very protracted eating disorder, and she had a very distressing relationship with her mother, and at Christmas time her mother gave her a very, very expensive set of kitchen knives, which can be hundreds of dollars, and they're very sharp. And as soon as she got back into her treatment community, we had to remove the knives. Now she can get a knife, from the Publix grocery store, but those knives, if she was going to do something based on her history, she would have done it with those knives because of the loaded meaning associated with it. And also, the CDC also has another study that shows to us that sometimes a person can be possibly chronically suicidal with a lot of forethought, even over years, but they might become acutely suicidal, and it's a matter of 5 minutes before they can sort of lose their hold on reality, and then they're into the attempt. So if it takes a person more than 5 minutes, or let's say 5 hours, that's a protective thing that we can do pretty easily. So I would also always include means restriction as a component of safety planning, and we'll talk about that in a moment. But there's one program somewhere, and I'm not sure in this moment where it is, but they require counseling with parents of young people or family members at an emergency room before they can go home and have their family member released from the emergency room. They have to have sort of a required consultation about suicide-proofing their home and making their home safe. I know that I have an adopted son, and there's just never been a way that we would have a gun in our home because we'd never have our family if it wasn't for important things like that. So there are ways to do public education, both pre-crisis and then, during or after the crisis as well. And then Fred Vars, who's not here today, he is a professor at the Alabama Law School. He has a very interesting initiative about voluntary reporting to, if one is worried about, like that mom who went to the blank blank store and bought the gun. He has an initiative which ASPARC and others are very supportive of, that one can volunteer to put their name on a do not sell a gun to this person, right? And I'll share a few more slides with you at the very end. That's an important kind of a new thinking outside of the box. And some of you might be thinking, well, gosh, if I did that, could I ever get myself off of that list? And the answer is yes. And some of you who may work with people who have serious mental illnesses or something like that, you might worry that that's going to set up a sequelae of other restrictions that that person might face, and the answer to that is no. And Fred can really speak to that in greater detail, but he has done such an exhaustive research process on how the rights of people would be protected, but also so would the safety if we had voluntary do not sell option. Okay? And then I just fall back on good old-fashioned voting. Voting at the polling booth with, think about who are you voting for? Do they support mental health initiatives? Do they support, safety? So there are a lot of things that we can do that maybe we, could get around cultural values that are really resulting in a high rate of death. I know in Alabama the gun deaths are much higher than they are in the nation. We saw that it's 50% or more in the nation, and it's closer to 75% for Alabamians who die from suicide with guns. And it's also much higher for women who use guns in Alabama too. Okay, so we're going to switch a little bit to assessment. And I know we probably have in here a whole range of people who some work with very up close and personal, day-to-day, individually with people in your counseling offices, and some of you may have a one-time encounter with someone after an incident, such as those of you who are first responders and law enforcement. So this is a little bit from alpha to omega, you might say, a little bit for everybody, but there's as much intensity that you can look further into. But all of us, no matter what our training or our experience or our vocational histories, every one of us can do suicide prevention. And the model that the nation recognizes for suicide prevention is a public health approach, even though we rely heavily on good mental health specialists every step of the way. But it's a lot like CPR, and we want everybody to know a little bit about something to ask the question, right? So in the next couple, 2 or 3 slides, I've got, if you don't work closely in a specialized credentialed form of mental health, you might see a little bit of your response on the right side of the screen, and others of you with more specialization, you might see yourself on the left side of the screen. I mean, just the opposite. So all of us, including friends and neighbors and members of our book clubs, and that guy at the sporting goods store could have asked that mother maybe a few more things as a gatekeeper, just based on an intuition. But maybe for our purposes here today, we probably have more first responders in here today and mental health professionals of all the different disciplines, and including people like Dr. Shelton, those of you who work closely in the medical system. So, okay, there we go. So when does one do assessment? Well, I would say always when you have a gut feeling that you should. Okay, always when you feel a twinge of worry. It bothers me when I hear people say, well, if they're not really talking about it, then there must be no worry. But if you still have a gut feeling about it, we should be asking the questions. Nobody can make someone suicidal by asking, okay? But for those of you with more clinical expertise in the room, I would say on the right side of the screen, always at assessment, I have a place on my intake form in 2 places for the client at the first meeting to say yes or no. And if they say no, I'm pleased. If they don't answer it, I'm worried. Okay? And then the last thing, it's at the beginning and the end. For those of you who work with people recovering from addiction or in treatment centers, obviously they can enter treatment with a lot of suicidal. It's a very, sort of like rock bottom can be a very destructive state of mind. As some people might even say addiction is a slow form of suicide. I can't argue with that. But you also want to reassess often, because as that person achieves sobriety, and maybe it's a year from now and they really are it's occurring to them, oh my gosh, I have really messed things up badly for my family and myself. And they may again have suicidal thoughts that were not unlike at the time of maybe their detox. So we don't just assess one time and then that's it. there are lots of life development going on between assessments and changes that people might be facing. Obviously, any high-risk group we would want to ask. If you use an intake form, put "Are you a veteran?" on your intake form, because if you don't ask, they may not really tell you. And sometimes veterans will go around the system to not meet with their own EAP, as they were talking about earlier. I once worked with a man who had been out of Vietnam for 30 years, and he told me not one single person, not even in his family, in 30 years asked him one single thing about Vietnam. And I'm like, oh my gosh, that is terrible. And so a buddy on his street got him connected to some other veteran groups, and then that began to be 30 years later, his kind of connecting up with his community. But you would also do it when, I'm trying to read, if someone's on a medication for the first time, definitely within those first 3 months, because people can start to feel better or have symptom alleviation, but they have not yet figured out new coping skills to get past what their core beliefs were about the state of their life. And so I always say, well, not 3 months, let's make it 6 months. And that's the part where counseling plus medication actually is very protective and even better than one of those two alone. But a person can have energy but not insight yet about other options that may be available to them shy of suicide. After discharge from a hospitalization is a very, very high risk time. And I do have a personal friend whose sister, her psychiatrist even petitioned her to be in the hospital, which she did go. She was in the hospital for a couple of weeks. He petitioned that she would remain in the hospital for another few weeks. And when she was discharged, she did not have an appointment with a mental health professional for 3 weeks. Well, it was not a week, and she was dead. So we have to have a better kind of wraparound care for those people. And even if it's your client and you think the hospital is liable for their care, the hospital is going to say, well, we're not liable after discharge. And so we have to have better, if nothing else, memoranda of agreements. Okay. Let's see. Transitions are very difficult, whether it's maybe a new medication, a new therapist, maybe a new level of care. Like in a treatment center, they may have more freedoms as they're getting more well. But those are transitions, and it can really trigger a lot of reverberations, shall we say, into the old scary thoughts of wanting to die as a means of coping or ending the pain. And then obviously at times of personal defeats or embarrassments or humiliations, that's the sort of the straw in the camel's back that can be the final straw for a lot of folks. And then obviously with disasters, and here's Alabama, we have a lot of tornadoes and hurricanes and oil spills and economic setbacks, and so we want to attend to people kind of, I think the word is trans-crisis, when someone can be in a crisis state but over a long period of time, because it's like it just keeps cascading on itself. Okay. Now, how do we do assessment? There are so many ways, and the one way you want to think about it is assess your person in more than one way, and I'll talk about that in just a moment. But we have a close association with QPR, which is the QPR Institute, and their public health gatekeeper training at the basic level is for all people anywhere in a community to learn how to do. It's kind of like CPR, but with suicidal warning signs at the heart of it. And the QPR Institute, Dr. Paul Quinnett, has several curricula that there's a curriculum for law enforcement and first responders. There's 3-hour and then a 6-hour training for school counselors, and then a longer one for triage responders. It's, I think, a distinctive trait of the QPR Institute is, even though they all cost a little bit of money, they're way more affordable than, like another program is the ASSIST program, which is good for communities and gatekeeper training. But it's, one time the QPR Institute trained 14,000 people at the University of Tennessee campus in one weekend. And they have an extraordinary system for being able to do a lot through technology and through large kind of mass appeal. So our little group, we've been doing QPR training, as have other partners in our grant history. We do a lot of training with smaller groups. Maybe our largest group has been about 60 people. But there's a curriculum online, a passcode that you get that you can keep for 3 years, and we do an in-class training to partner with the online training. So it's a fairly accessible resource for not a lot of funding. And but going beyond that, in terms of how would I assess someone, I do plan to go to a list of several mnemonic devices that you might even have in your notebooks if you're driving a police car, or if I like to call it the red folder approach. So you have everything you need related to suicide assessment and documentation in your red folder, and it's just with you. So, but you can assess somebody through an interview by using the appropriate questions. I'll give you some ideas about that. Lots and lots of paper and pencil options out there that either the clinician can administer or the individual can take. Some are very involved, some are very, 8 questions. Depending on your setting and how much money and time you have and kind of how you need that to work with your clientele, then you would pick the one that best matches all of those conditions. But another option would be triangulation. And I know some counselors, we think of triangulation as like a bad thing, like, ooh, mom and dad triangulated Susie or Johnny. But in this case, it's kind of a research technique where you would have inter-rater reliability between 3 methods of assessing. So I'm going to give you some ideas about that in the next slide, I think. But there are some people who have a model or an approach. For example, David Jobs has a model called the CAMS approach, and it's the collaborative assessment of and management of suicide. And I'll point you to that in just a second. So ongoing training like this. Now, this is partially a little fun thing in our brief time together here. And these are all acronyms that you could use. You could have these in your red folder. And you could just start taking your highlighter. And I wrote a chapter for a textbook, and I did not include pimp, dead pimp, my pimp, or pimp dads in my chapter. And I was sternly advised that I should include those. So right now, you're going to figure out what those mean. The one that I like is Pathwarm. That was generated by the American Association of Suicidology. And Simple Steps is a little bit more complex, but it was developed by a counselor. Sad Persons is a kind of a depression inventory, but Suicidal is one that I think those of you first responders are going to be very interested in. So let me show you my next couple of slides. This is going to, and I'll post all of this on aspark.org for you to download. Okay? So it's a lot to read. It's very tedious. The letters get smaller and smaller, trying to jam all of this in there. But obviously, is path warm? You're looking for, is the person ideating, substance abusing? Have they lost purpose? Are they anxious, trapped, hopeless, withdrawing, angry, reckless, and having mood disturbance? So, but you'll have this, and you could even highlight everything on the sheet. There's some overlap between these. One of the ones that I like is on the bottom of this slide called Man, This Isn't Fair. And that's a long one. So to me, the more constructs, the more sure I would know that, there are more indicators or not, hopefully. But let's see what pimp and my pimp stand for. You can see these others here. They're much shorter. Oops. Let's go. So here's pimp is having a plan, intent, means, and prior attempts. That does kind of get down right to the core things, because a person, I'm going to fly over it really quickly, but a person can have a desire to die. Like, I feel like dying. I want the pain to end. If I got in a fatal car accident or if I got a terrible illness, I wouldn't mind if I died. That's fairly passive, but there is a desire. But when they have desire plus capability plus intent, and intent is the most important part of that equation, and a lot of people confuse intent with choice. Like, he chose to die, he chose to kill himself, he chose to end his life, or she did. And the national experts that I'm attached to really do not see suicide as a rational choice. Nowhere on the CDC cause of death ranking is there a column that says she committed a hostile, selfish act, angry towards her family, and killed herself for revenge. That's not a cause of death. It's illness related, plus all the other multiple factors that do create causation. But dead pimp, my pimp, pimp dads, you can see all of those, and I'll post this for you. Oh, now why am I going? Okay, let's see. All right, so what I'd like to do is maybe look at the Word document that we had talked about in the technology booth back there. This is especially for you law enforcement folks. Now again, the print is really small, but under suicidal, and so that's a mnemonic device, and that's an acronym. If you could scroll just down until you see the yellow highlighting. Okay, so Streed, who generated this, has the word suicidal in general terms, but then he added what might be the indicators of someone who is about to, what they now call subject precipitated homicide, what we formerly called suicide by cop. Is there anyone in here that has had an experience or an encounter like that? Or you know of it through your colleagues? I remember at the crisis center there was a murder, and then the person who killed his wife engaged law enforcement in a way that he seemed to hope that they would shoot him. Now, that particular incident I'm thinking of, he didn't die, suicide by cop. Now we would refer to it as subject precipitated homicide. But what Street has done is list the things that are another indicator of someone who might be in that particular state of mind. So under S, he thinks that stigma avoidance is what that person is thinking about. I don't want to kill myself because of the stigma associated with it. I don't want to not get my family's life insurance policy if they don't pay it, if I die by suicide. Another S for the S letter would be strategic planning, self-causation, sensational death, or symbolic intention. So if you go through the whole handout, and I'll post this, for those of you in law enforcement, you could see what some of those acronyms stand for. So maybe you could scroll to the next page on that document. So for you, the person understands the consequences, and then let's say, I guess this would be the next letter, C, control of impulses is numbed, confrontational interaction. So in addition to the other indicators or warning signs that might be for any suicide prevention interaction, this is specifically tuned into those of you who are first responders. So just, it's one of the rare things like that I tend to see in this material. So we can go back to the PowerPoint. And I know we have about 5 minutes, so I'm going to load you up with lots more resources here. There are tons of paper and pencil assessments you can look at, and I'll show you where to go for more lists for those things. I think I'm going to just finish out with a lot of the resources that will help you that you could even use today. I would just say clinical judgment is always important. There's no cookie cutter recipe. You can't just know this one will, this one won't. And it's a little bit like you don't want to get a false negative, for example, on a pregnancy test or a false negative on a cancer test. You don't want to have cancer, but you don't want it to be missed if there is. So the lower left quadrant there is the most worrisome, followed by the second quadrant where it's a false positive. Okay? I think the client is suicidal, but they're really not. So that's kind of misdiagnosis, and that's something we can get through, but it's difficult to get through a false negative if the client is deceased. Okay. Now, I'm just referring you to a lot of other resources for you here, but the AAS and the Suicide Prevention Resource Center wants for all of us to, at the very least, be versed in risk factors, warning signs, acute or chronic level of risk, and low, moderate, or high level of risk. And so these next few slides will help you to sift and sort that. So that's someone with the highest risk is going to have those acute. Usually it's someone who something happened yesterday or the day before. I think about the Vince Foster suicide. He was an attorney in the Clinton administration back in the day, and he did have a pocket full of Prozac in that park where he shot himself. But his, Washington can be a pressure cooker of a place. There was probably a something that happened. But a chronic suicide would be somebody like Marilyn Monroe. Lots and lots of years and decades of relationship difficulties and on and off again, substance abuse. So acute versus chronic. The chronic one is going to probably have ups and downs over time, but an acutely at-risk person, in 24 hours or less, you probably need to get them some kind of care or safety, vigilance. Okay, and then here's another way to sift and sort. Warning signs go along with acute signs. Risk factors are a little bit more akin to chronic suicidality. So, a lot of you, maybe you had a parent or a grandparent who had maybe an illness, and every time you go to the doctor, they ask, well, did your mom or dad have this or that? So you have a marker or a risk factor for that condition, but you may not have it. So those are what risk factors can be like here. Okay? Now this is one of the niftiest handouts if you were not sure if the person is in high, moderate, or low risk. This is directly from the crisis center. You should not just use one thing like this, but if you had to have one thing, this would be very helpful in the moment to discern, is this person at low risk? They're talking about, I'm going to eat fried chicken every day for the rest of my life until I die. That would be low risk. Not zero risk, but low risk. If they don't have other factors such as intoxication, or if they have a high degree of ambivalence, or I'm not sure I'll really do it, then that would be low. But somebody with a plan, with intent, with a means, with a method, with access to that, with a way of being not detected, that's high risk, and they probably need to be in emergency care. Okay, I'm going to skip through these. Here's some thoughts for you about intervention. What I would say is that all intervention is customized to the individual. So one person might say, I might ask, do you think about suicide every minute of every day, all week long? No, it's just on Fridays when my kids go to their dad's house. Oh, okay, now that to me right there speaks treatment planning. What are we going to do to make Friday afternoons safe for that person? No, it's not that. It's just on Monday mornings when everybody else is going to work. And I don't have a job. I haven't had a job for a while. So that's treatment planning. So you would customize a lot of your treatments to that. But I will say, we don't have time, but no harm contracts are not what we do anymore. And if you're still holding on to that, you're just kind of behind the times, just saying it that way. So safety planning, and on the website we do have some examples of safety plans, and I'll list for you here what I think a good safety plan should include. Right here in the middle where the red dots are, your safety plan should include means restriction, 1 or 2 ideas about how you're going to do that. Do not rely on your client to make sure that that happens. You want to have a family member or a friend help to ensure. Self-soothing. What behaviors can they do when they are distressed? What self-care options can they do? 3 meals a day, take a break, take naps, get good sleep, take your vitamins, have boundaries, say no. Family involvement, who's the safe person? Or any person, family or otherwise, that can be on your team with you. And then community resources, and I heard someone say chaplains often in rural areas are big resources, and they probably are also burned out and traumatized, but in your community you are looking for anything like that. Even on a safety plan, going to Walmart at 3 o'clock in the morning is a safety measure, because there are people at those 24-hour Walmarts. That's something to do in those really awful hours. Okay, and then crisis response. But let's look at some of the resources here. I've got tons of YouTube videos if you want to look at more to see about assessment. So I haven't watched every one of them minute for minute, but there are lots there that I kind of vetted. This is our website, and then I really want for you to download the app that you could put on your phone. And every single one of you can do this, plus people you know can do this. SAMHSA just released a phone app for suicide for the questioning process. And then even down here in Little Alabama, they have a therapist or a treatment locator. So it's very good, and I have it on my phone even though I feel like I know a lot about what to do. There are also a couple on there that have to do with safety planning, and then some of these others, and once you get into these websites you'll see bunches of apps for the consumers to have, like Calm Down or Get Through Your Angry Moments or mindfulness things. There's a great one called Headspace for meditation. And these are fantastic things for people who are kind of, attached to their technology. You can download that right now. Here are some things about nomenclature and how we think about suicide in the most up-to-the-date way of talking about it. So it's best to say, and this is directly from the CDC, died from suicide. It used to be completed suicide. Now they say not even that. So I've got a couple slides there, but let's see. This one, the guide is really a best practices website for educators. But if you look past that, it's meant for school personnel, administrators, parents, counselors, teachers, and just look at, they have everything, handouts, forms, rationale for everything, pre, post, and intervention. You can modify it and adapt it to your particular type of setting, public mental health or a private practice or anywhere else. So that's a good resource. And then here's all of the phone lines that may be helpful to you. Here's our state crisis center numbers and their websites. Here's some more. Some school-based programs, and then my references. So the last thing, well, here, I know I need to do this. So this is just a snapshot of our website, and I just included the link, and that's what you'll see when you go to our website. But if you go to the next page, you'll see up there in the upper right corner, it says Resource Directory. And the University of Montevallo has given generously of their IT and cyberspace to help us put tons of stuff on our site that will help mental health professionals and professional helpers. But there's also a few things on there for bereavement and for people who may be actively suicidal. So up in the upper right corner, the top yellow button is for mental health professionals, and that might be the place that most of us would check. If you wanted to look at those assessments or a sample safety plan or the phone apps or anything that we can post on there with respect to copyright, we will put it there, okay? And then let's see here. This is a link to Dr. Var's initiative. He is on our board, so it's not like he's somebody outside of the circle. He just couldn't be here today, but that's on our website. And then his slides will be posted there too. And I know that he has collaborated on this with Dr. Shelton, who was here this morning, and he has some thoughts about it here. This is a sort of a human interest story right here. One of his colleagues, a law professor, came to work and shot herself with a gun. And however which way all of these things came together, he wants a voluntary do not sell option for people who may want to act in their own, it's almost like participating in their own rescue. And we like for that to happen. We like for people to have as much autonomy over their own safety and health care, right? So some people fear that this would get all gummed up and their file somewhere out there in the world would be jeopardized. But Fred assures us if I work at that pawn shop or wherever guns are sold, you know, that person who is required to call, they're going to get a yes or no, and that's it from the FBI, I think. So I'm going to, he has some data to show that people would sign up for it if they had the option. And it's just kind of a good thing. It'd be like if you told Applebee's, I can't have any peanuts in my salad. You know, I'll have an anaphylactic reaction to it. So we support this. So I know we are out of time. I just wanted to say that some of the research that's also happening in trauma work right now is something called post-traumatic growth or post-traumatic resilience. And that's kind of the good side of what we do. We do have our nightmares and our stress and our troubled coping skills when we've been exposed to trauma too much. But the other side of that coin is that I bet I would feel safe being with any of you in this room if I were in a psychiatric emergency. I bet I would want to be that family that called the ambulance EMT, I forget his name, but he said they found him later to thank him. And I'm like, wow, that's what we live for. You know, this is a purpose-driven life that all of us do. We do the work where angels fear to tread. And we probably don't get thanked enough by anybody that we serve. But to me, I get kind of energized by doing this work. I feel like I do watch a lot of football with my husband and my son, but I like the rewards that I have doing this kind of work too. So you might want to think about, where do I put trauma and trauma exposure into my holistic view of myself or yourself. And to me, there's incredible dividends and rewards from feeling like you in this way. So I'll stop there.